Thank you everyone for joining us tonight. This is our very first Abre Venous Symposium, which, as you know, coincides with our recent FDA approval of the Abre Venous Stent. This represents a huge landmark. Bringing a product to market is a very big endeavor. So I want to take a moment to congratulate all of Medtronic, from the engineers to those who helped conduct the trial to those involved in getting the product to us, as well as the investigators and physicians in the trial and the patients. So we'll get started tonight. I'm Dr. Erin Murphy. I'm the director of the Venous and Lymphatic Institute at Sanger Heart and Vascular in Charlotte, North Carolina. And I'll let my colleague, Dr. Paul Gagne, introduce himself, although of course he needs no introduction to many of you.
Thank you, Erin. You're too kind. My name is Paul Gagne. I'm a vascular surgeon in Connecticut. I'm part of the Vascular Experts partner. We're a large vascular surgery group of 20 surgeons in Connecticut with a special interest in deep venous disease. It's a real pleasure to be part of this tonight. It's a great time to see this launched.
Dr. Gagne and I will go through one of our cases each from the IDE trial and show you what Abre can do.
That was excellent. I have to say the data is so impressive with the population that was enrolled in this study. We've had good outcomes to date. So this is a patient who we ended up putting a stent through the external iliac vein, a post-thrombotic patient. And these are my disclosures. So this was a patient in his 50s who presented with left lower extremity post-thrombotic syndrome to our clinic. He had a history of a provoked DVT 6 months previously in his left lower extremity. He was morbidly obese, he had type 2 diabetes, a non-smoker, but he had no history of cancer. When we saw him, he had chronic left lower extremity swelling and heaviness. The symptoms pretty much started after his left lower extremity femoral popliteal vein DVT 6 months earlier. And on physical exam, he had circumferential skin damage to the calf with hyperpigmentation and a generalized ache. So it seemed that the symptoms were pretty severe for somebody who had just had a femoral popliteal vein DVT 6 months earlier. His SEEP score was a 4A, his Villalta score was an 8, his VCSS score was a 6, and his EQ5D was a 90. So we did an ultrasound, and what we found of the leg was that the left common femoral vein was widely patent with phasic waveforms. But if you look here on the right, these are phasic waveforms in the common femoral vein. Here you see a clear interruption of flow intermittently. The phasic waveforms on the left were somewhat different, and there's almost a continuous component between the phasicity that there is a hint of here, suggesting that maybe there's something going on in the iliac vein on the left, besides just the DVT that we had already recognized in the femoral popliteal vein segments. The common iliac vein was not well seen on duplex imaging, and again, a morbidly obese gentleman. But we did see scar in the femoral vein and popliteal vein, but the deep femoral vein was open and there was no acute thrombus. The greater saphenous vein was patent and dilated and incompetent. So that was part of his venous disease. So we did a single view venogram. You can see it live here. There's an area of narrowing suggested here in the external iliac vein and maybe a little compression of the common iliac vein here. And we performed intravascular ultrasound. This is the area of stenosis we identified in the external iliac vein. This is the run through the external iliac vein. Here you can see the vein is sort of diffusely small, some hyperechoic echo around the vein, suggesting perhaps a post-thrombotic process. You can see how narrowed and diffusely through the external it is. And you can see here that the area of this area of maximal stenosis was only 39.5 millimeters. Typically, we'd like to see that 100 to 120 minimum. And actually, let me just show. You can see here in the video, here in the lumen, there's some scar popping in and out here. So this is not just diffusely small and sclerotic, but you actually see shadows popping in on the ibis, showing some intraluminal synechia, consistent with a post-thrombotic process. So when we reviewed the images, it looked like the external iliac vein had a 60% stenosis, as you saw. The external iliac vein cross-sectional area reduction by intravascular ultrasound was 74% compared to the reference vessel, and we'll show that. And then you had a little bit of compression of the inferior aspect of the common iliac vein on intravascular ultrasound. So it wasn't a critical lesion, but it was adjacent to this diseased external iliac vein. When we looked at the length of the disease segment, it was about 70 millimeters in the external iliac vein by both IVUS and venography. And I typically, if I see even a moderate stenosis like this in the common iliac vein, I like to try to address it. Given that we now have long stents and there's not much of a price to pay for using a long stent as long as it's landed in the right place, I treat these moderate lesions as long as I'm not going to be adding additional stents. And so we brought this patient to the procedure room. The plan was to identify the lesion, or rather had the patient in the procedure room. The plan was to anticoagulate. We wanted to pre-dilate for all the pre-thrombotic or post-thrombotic disease, the scar. I routinely pre-dilate. In this case, it was the external iliac vein that appeared to be compromised with scar. So we pre-dilated that area with a 14 millimeter balloon based on our IVUS measurements, which showed the reference vessel was about 14 millimeters. And then we stented with a 16 millimeter by 150 millimeter Abre stent. We went through the entire external iliac vein into the common femoral cranially, and then in the common iliac vein, we extended above that inferior common iliac vein stenosis, that 40%, to about the mid to upper part of the common iliac vein. And then we post-dilated the external iliac vein segment with a 14 millimeter balloon, given that that was the measured size of the external, and the common iliac vein we dilated to 16 millimeters. And I generally like to oversize the stent in an area of capture of 1 to 2 millimeters, consistent with the IFU. So given that the external iliac vein reference seemed to be 14, then we chose a 16 millimeter stent, which was oversized by 2 millimeters in the external and therefore would anchor in the external iliac vein and not embolize. But it was also the appropriate size for the common iliac vein to treat that 40 millimeter compression lesion. So this is pre-dilating the upper external iliac vein down through here and into the upper common femoral vein here. This is a 14 millimeter balloon, and typically these lesions will open up and all webs will be broken up at low pressures, usually less than 8 atmospheres. This was our lesion. Here's the area of stenosis we talked about on IVUS. This was the reference vessel you can see here. If you look at the measurements, this was 149 millimeters squared. You add up the minor diameter and the major diameter. This is 10 and 17.9, or just about 28 divided by 2 is 14. And that's how we arrived that the reference external iliac vein measured about 14 millimeters, as I've been referring to. And then we deployed the Abre stent from the common iliac vein down to the upper common femoral vein. I dilated with the 14 millimeter first in the common and external iliac veins, and then with the 16 millimeter balloon up in the common iliac vein. And then this was the lesion we started with, and this is the post-stent IVUS. You can see we're in the common iliac vein here. We transition to the stent here very nicely. The area of narrowing within the external iliac vein is gone here. And now we're in the common femoral vein, and there's the bifurcation of the artery. Let that run again. Iliac artery, common iliac vein, stented common iliac vein, and external iliac vein. We're in the common femoral vein right here. You see the artery splitting, and that tells you your common femoral vein has been completely imaged. And then our lesion pre-stent, post-stent, and then this is our flow. You see no collaterals. You see brisk and spontaneous washout of contrast. That predicts stent patency. If the contrast is stagnant, then you got to be worried that your stent is going to thrombose. So this patient did well. My post-thrombotic patients, I put them on Lovenox, a milligram per kilogram Q12 for 4 weeks before initiating an oral agent. And I usually start this right in the recovery room, so there's no gap between the intra-procedure IV heparin we give and anticoagulation. And then we started him on Xarelto 20 milligrams a day for 6 months. We gave him intraoperative fentanyl for the procedure, which helps with the balloon dilatation of the scar tissue. But post-op, we typically don't need to provide any pain medicine, and this patient just took some non-steroidal. So again, not oversizing the nitinol stent, but sizing it per IFU appropriately tends to avoid that excess pain that some patients report post-op. Then the patient wore compression stockings. We had a duplex ultrasound at 2 weeks, which we like to do it early. On the small chance that we see a stent thrombosis, we want to be able to intervene early before that thrombus organizes and is difficult to treat. And his ultrasound showed that the iliac vein stent was widely pained. Then we also look at the access site in the femoral or popliteal vein to make sure there's no DVT at the access site. And then we saw the patient again at 4 to 6 weeks, and he was fine, and 6 months and annually as per our protocol. Ultrasound and physical exam at those visits. And what we found was that even out at 2 years, the patient's symptoms had gotten better. He had less swelling, achiness, and inflammation. The left calf was much improved, and this was a persistent benefit at the 6-month, 1 year, and 2 year follow-up. We ended up treating his left greater saphenous vein. We used VenaSeal closure system as our preferred system over the last 2 years because of the decreased discomfort, and we found less complications and high degree of success. The patient, because of his skin damage, will always be CEAP4, but his symptoms are much better. But in order to prevent progression to ulceration, perhaps in the future, we treated a superficial vein as per the recommendations of the SHAR study. The Abre Venous Stent is a self-expanding system, and what we saw was excellent expansion from the baseline lesion to the post-stent lumen. And this lumen gain is predictive based on the video trial of clinical improvement at 6 months. As I mentioned, we don't tend to oversize more than 2 millimeters. That's a prescription for pain and is really unnecessary. And I find that the Abre stent, its visibility, its ease of use with the triaxial delivery system, and its excellent opening capability for these complicated lesions is a welcome addition to our armamentarium for treatment of chronic venous disease. Thank you. Erin?
Okay, thanks, Paul. That was perfect. We're going to discuss one more case. So this is a case of mixed superficial and venous disease. Although looking, Paul's case was too, which makes a good point, is these things don't occur in isolation. You really need to manage the patient's entire venous system, both superficial and deep, as well as their reflux and their obstruction to the best that you can to get them to the best clinical outcome. So this is a 65-year-old male who since 2006 complained of left lower extremity, varicose veins, progressive edema, and recurrent venous stasis ulcer that was pretty severe and never really stayed healed for any length of time. In 2017, he had an acute worsening of his condition. He presented with an open wound with a left femoral popliteal DVT. I suspect there was iliac involvement at that time, but it was an inpatient exam that he had, and we were not directly involved at that time, and nobody looked as high as the iliac. He had wound sepsis at the same time and underwent multiple surgical debridements by general surgery, had a fairly complicated hospital course. Vascular was consulted and followed up outpatient after his acute debridements. At that time and shortly thereafter, he had this large ulceration, which I'll show you a picture of, severe hyperpigmentation, LDS, just really bad skin changes, lifestyle limiting pain, and edema. His venous metrics, this is actually after his initial treatment, so I'll go through this, but CEAP6, Villalta 12, VCSS 18, all very kind of debilitating scores. His initial ultrasound, he saw a colleague of mine, and he had chronic non-occlusive disease in his left femoral popliteal veins. Again, nothing looked in his iliac at this point. He had deep axial reflux, meaning the common femoral, and popliteal veins were all refluxing. He had superficial reflux in multiple veins that were quite large, and he had multiple large varices around the wound. So At that point, he was treated with GSV, SSV ablations with the closure fast system, and he also had some treatment of ulcer bed veins via direct injection to try to improve the ulcer. Here is some of his pictures before and after that initial treatment. So here's how he presented after his wound debridements with maximal wound care. And then here is after the superficial treatment, but this is where those scores were actually taken, is when he eventually got to me at this point. So he still had pretty debilitating symptoms. And while you can't quite tell in this pictures, but he had pretty bad swelling and a lot of leg pain out of proportion to what should have been left after he had his superficial system treated. And he was still getting these small areas that were opening and weeping, although he certainly had a substantial improvement from those superficial procedures and they were clearly needed. We felt like there was something more. So we put him through some more testing, and on his ultrasound, again on reflux, he again demonstrated the deep axial reflux, but he also had a small open segment of the GSV from his low thigh to upper calf with veins feeding the ulcer bed. Again, so what predisposed him to failure is one thing that can make you look for obstruction, in addition to the setting of pretty severe skin changes, probably out of proportion to superficial disease, as well as all the swelling, which is often out of proportion to superficial disease alone. So we looked at his iliac veins, and he had moderate narrowing throughout his system. He had, again, non-occlusive disease in his fem-pop veins, but had a patent profunda, which is important to note when you're assessing these patients for stent candidacy. Do they have a good inflow from at least one of those two vessels? So he had kind of, in my mind, 1.5 good vessels out of 2. So the plan for him was to, again, maximize everything, to re-ablate the persisting refluxing segment. It was long enough to treat, perform phlebectomies of the large varicose veins that serve as a reservoir to continue to contribute to his ulcer, and then take him to cath lab to treat any identified obstruction. So after his initial treatment with his superficial system, we took him to cath lab. You can see kind of that he has just a ectatic looking kind of ratty venogram. There's no horrible stenosis identified, maybe around a 50 to 60%, but just kind of ratty looking vessels, which was also seen, we'll show you on the IVUS. What we found was a diffuse ectatic kind of diseased vessel with maximum stenosis of only around 53% by IVUS in the CIV and venogram around 60, but a very long lesion, 170 millimeters. So why treat something like that? If it was a 50% May Thurner, would I treat him? Probably not. But based on his severity of symptoms, the presence of reflux, which makes any obstruction more obvious and more clinically significant, and then a very long lesion. And in veins and a low pressure system, the length of lesions really matters. So we did decide to go ahead and treat him, and I'll go through the treatment plan as we go. So going to stent sizing, we before you balloon and start treating, you really should know what you're going to be using. And as Dr. Gagne mentioned, you don't want to massively oversize these stents because the patient will have significant pain, and nitinol really doesn't tolerate massive oversizing. But you do have to use judgment. You're told to go 2 millimeters compared to normal segments, but in a patient like this, what's normal? And when you're looking at a stent that's going to go from the CIV to EIV, you're looking at diameters here of 14 in the EIV, of almost 18 in the distal CIV. What you really want is a stent that's long enough that it's not going to move and that it's really anchored with no more than 2 millimeters oversizing for the most part. What I did was an 18 stent on him up top, because you also don't want a stent that's too small for certain segments, such as his distal CIV. So again, judgment call. And I did a 16 distally, where he's got average diameters ranging from 12 up to 15. I'm not sure if you approach these patients the same way, but the nice thing about doing it this way, you can actually put the distal stent first and then put the 18 inside the 16, because it's not going to get bigger than a 16 when you're in this segment. And it further anchors your stents. So there's a little bit more decision making with sizing and planning your overlap, making sure your overlap is not underneath the inguinal ligament. I never use stents that are shorter than probably at least 100, and that they all at least anchor in the EIV if I'm doing a CIV stent. No skip areas. These are all very important when planning your stent sizes and lengths. So these are just his, dilations of his segments. We don't need to spend too much time there. I will say I generally go to pretty high atmospheres. I always balloon 2 stent profile. If it's going to be a 14 stent, I'm going to balloon to a 14. Sometimes I'll even use a slightly bigger balloon. You want to do all your work with the balloon. The stent is not designed to work. The stent is designed to hold everything open. The balloons are stronger than the stents. Then stenting followed by balloon profile. When I'm balloon profiling my stents, I typically only take it up to 6 atmospheres, which is nominal on the balloon. These are our pre and post procedure images, and you can see a much more uniform looking vessel compared to prior. So post-care, I do similar. I do place my patients under general anesthesia just for pain control purposes. Toradol in PACU and then Q8 or NSAIDs for the first 24 hours. I also do Lovenox 1 milligram per kilogram. I think there's something inflammatory early on with these patients. I don't see as much buildup since I started doing that. I would love to get mine to do 30 days, but I think 2 weeks I've been is enough of a sell sometimes. I think it's still pretty costly and people don't like the injections. And then I typically switch to an oral anticoagulation with aspirin long-term. But you have to look at your patient comprehensively when deciding an anticoagulation. One of the things I see fairly often is patients come off it too soon. This patient, for example, is on long-term prophylactic anticoagulation. He has deep axial reflux. Every valve in his deep veins are broken. He has history of prior DVT, possibly 2. He has thrombotic inflow disease left in his femoral vein, which is feeding his stent. He has moderate activity levels. I wouldn't call him overly active. And stent occlusions are just super difficult to treat. So preventing them is very important. I do similar stent checks to monitor for any problem early and then back off after that first year when generally they do pretty good. And then I encourage them to keep their calf pump strong, to manage their weight, to continue compression, to really optimize the outcomes on their end. So here's his final progression. So again, prior to any superficial or deep treatment, after superficial treatment alone, still significant disease, but vast improvement. And then really a good outcome for this patient who's really been in a bad place for the 10 years prior, after maximizing both systems, even though he still has remaining deep reflux, he is in now a pretty functional state.
Great case.
In conclusion, patients with venous disease require a comprehensive management strategy with evaluation and treatment of both the deep and superficial systems, as well as their obstruction and their reflux to the best that can be done. Importantly, look for deep venous disease when presentation is out of proportion to the degree of superficial disease, as in both of our cases that we talked about today. Closure fast as well as VenaSeal are effective and safe tools for endovenous superficial vein closures. Abre venous stent is an excellent tool for treating deep venous obstruction. An important point, as we both brought up when stenting with nitinol, and probably the key difference compared to our experience so far in the US, is to plan your sizing accordingly, including no overlaps, and plan it all prior to your venoplasty based on your patient's anatomy. Thank you.